afternoon, everyone, and welcome to our gLocal Solution Room this afternoon. I'm Heather Loveday. I'm Professor of Evidence-Based Healthcare at the University of West London, and I'm also the Director of the JBI Centre at the University of West London. I think we'll wait a few minutes while we're waiting for attendees to dial in. We've only got a small number at the moment, and I'm expecting around 20. From the registrations. So hope you're all sitting comfortably and getting ready for an exciting afternoon. I'm going to just introduce my co-panelists today. So Professor Jackie Prieto is Professor of Nursing and Infection Prevention at the University of West London and also a clinical academic at the University of Southampton Hospitals. And she's been working with the infection prevention and control team there. And also Sophie Corbett, who is with us. Sophie is a registered care home manager of Care Plus and has implemented a programme of work around improving hydration in older people in residential care. I'm very much looking forward to hearing her presentation. We're actually covering 3 issues, if you like, this afternoon. The first is how we actually have accumulated our evidence around preventing urinary tract infections in care homes. That's going to be followed by an issue around co-production and how we might actually co-produce with people who are working in care homes to ensure that we can get our messages across. And then the third bit is Sophie talking about her particular projects and how she implemented changes to enable care home residents to become better hydrated and prevent urinary tract infections. And then at the end of the session, we have a brief panel discussion. If you have any questions that you would like to ask, if you'd like to pop them in the Q&A section, if you look at the bottom of your screen, you'll see Q&A, and you can actually put your questions in there. Alternatively, when we get to that section, you can put your hand up and I will call on you to do that. So we don't seem to have more of our panelists at the moment, but I don't want to start too late. So I'll get going with the first bit, if you like, and then we can actually carry on. So I'm just going to give me a minute to share my screen with you all. So what I'm going to do is just give you a little bit of an introduction to JBI and what we are, just to give you some background as to what a gLocal Solution Room actually is. It sounds quite scary, but actually it's very, very practical. So JBI is an international collaboration across the whole world. There are 85 entities in the collaboration, and if you like, our aim is to provide better evidence for better outcomes, but also to ensure that those outcomes are implemented in practice. It's a leading evidence-based healthcare organisation. We produce evidence, education, software and research, so we work across the evidence sphere. We're working across 40 plus countries and, as I said, around about 85 entities. We have partnerships with experts across the world, and JBI at UWL is actually part of the European region. We work very closely with our colleagues across Europe, and our main aim is to actually improve health outcomes. JBI's vision is better evidence, better outcomes and a brighter future. And the mission is to promote and support evidence-based healthcare, not just the synthesis of the evidence, but actually how to get that into practice. So we do that because we recognise that healthcare is more than just effectiveness. And the collaboration is unique in that we look at how big the problems are, why is there a problem and what the likely causes are, how do patients feel and what do they prefer, so looking at qualitative evidence as well as quantitative evidence. And then how important is the context in which care or advice is actually given in that sphere. The JBI model of evidence-based healthcare is multi-component, and it is focused particularly on the feasibility, appropriateness, meaningfulness, and effectiveness of care. So is it practical? Is it appropriate for the context and the people that we're looking after? Do the people we're looking after actually attach meaning to it? And how effective is it? In terms of global health, we're trying to make sustainable impact through engagement and knowledge needs. We have an evidence generation sphere where actually what we're trying to do is produce evidence, synthesize evidence, transfer it so that people understand what there is out there, so active dissemination, how we integrate it into systems, how we can put it into education. And then perhaps most important of all, bridging the gap between the evidence and its implementation. So focusing on the context and an analysis of what needs to happen in that particular context, being able to facilitate the change so that it's meaningful to practitioners and patients alike, and then to evaluate the processes and the outcomes to make sure that what we've done actually works. So we're essentially trying to bridge the research practice gap in everything that we do. So we have a fairly pragmatic approach to implementation, and the framework is very much similar to those used in the NHS, which is looking at what practice area problems are with stakeholders, so with care professionals, with residents, with patients, with relatives, engaging people who can help us facilitate the change, ensuring that the context is ready for change. So are there things we need to do within the care settings before we can actually implement change? Look at what's already happening to make sure that we're not trying to make people do things they're already doing. So recognize that there is always good practice within care settings and actually look at what needs to change against that. Implement our change using a GRIP framework or a PDSA framework, reassess practice, think about how we make that change stick, and then if necessary, start the process again to look at what we can do better the next time around. So our global reach is for 83 entities. You can see them on the JBI collaboration here. And you can see that they are largely spread across the world, a couple in South America and quite a large preponderance in Europe, as you can see, Africa and Southeast Asia and China. So we are actually the largest global collaboration. We have global entities that promote the use of evidence-based healthcare, and we each lead our own particular initiatives across the world. So glocalization is about trying to think local and then apply that globally. If we all just keep everything in our own silos, we never learn, and there's masses of good practice across the world that we can learn from and adapt to our own contexts. So if you go back to the JBI model of evidence-based healthcare, you can actually see that the global health component is really, really important here. And we're trying to ensure that culture, capacity, communication, and collaboration are actually at the heart of everything we do in order to move evidence both locally and globally to improve patients. So working globally is about local knowledge being disadvantaged because we can't actually spread it. And what we want to try and do is actually move that globally across international borders and cultures. So the gLocal solution room is actually a way of translating what we know from research into practice, moving our evidence-based interventions, using different strategies, and thinking about what works in one context of care may or may not work in another setting. And therefore we're trying to look at how we can actually change the variables that matter in implementation. If you're interested in connecting with JBI, you can actually do that through a range of social medias, very active on LinkedIn, Facebook and Instagram. And you can see a range of YouTube videos available to talk about the model in more detail. So with that, I'm actually going to move to our next session, which is to present the evidence that we have for our topic this afternoon. Around about 4 or 5 years ago now, colleagues and I formed a review team to undertake a realist synthesis of the approaches that could be taken to preventing urinary tract infections in older people living in care homes. The work was funded by the National Institutes of Health Research and involved a range of, as you can see, collaborators across the UK. We also had a project advisory group and a group of stakeholders who helped us focus on what we were trying to do. So this was not, if you like, a systematic review. It takes a very different approach. So we weren't looking necessarily at whether or not we had evidence for super effectiveness. We were looking at evidence that would actually help us to develop some explanations that would help inform the practice of early recognition and prevention of UTI and catheter-associated UTI in older people living in care homes. And I'm not going to focus that much on the methodology this afternoon, because I want to actually get to what we found and how we can use that, and then enable Jackie and her colleagues to actually talk about approaches to implementing this in practice. So realist synthesis is a way of finding out what works for who and in what circumstances. So the jargon around this is that context is important, the way in which the context is actually affected by mechanisms, so the resources and reasoning that staff have to actually implement changes, and what that outcome might actually be. And those things are actually called CMOs, so context, mechanism, outcome frameworks. What we actually did, just in summary, was we did a scope of our review. We retrieved a very large amount of literature to appraise and take data out of. And from that, what we tried to do was develop some initial ideas about what might work and why it might work, and the process by which it might work. In the third stage, we actually did a synthesis of the evidence, and we, if you like, firmed up our ideas about why things actually worked or not. And we did a range of stakeholder interviews to make sure that what we were finding actually fitted with what they as residents experienced, as relatives experienced, or as practitioners within care homes experienced. And then in our final stage, we actually again talked with stakeholders and project advisory groups to get their input into what our theories actually said. And we've had an active dissemination strategy, which has involved focus groups with policymakers and also with practitioners. So a process of looking at the evidence, which uses systematic approaches, but which actually is not focused entirely on effectiveness. So resident and stakeholder involvement is really central to a realist synthesis to ensure that our review included all types of perspectives, also that it focused on what was important to care home residents, their families and others, to make sure that the decisions were jointly made at key stages of the review, and to ensure that our findings and outputs fit the settings and the needs of end users. Often evidence is a systematic review, which says, here's the evidence, go and do it yourself. And what this approach actually does is take account of how the processes that make evidence work can actually be contextualised within care home settings. So we had a large group of stakeholders, just to give you some idea. We had a project advisory group, which had some specialists, international, and also some PPI representatives, so experts by experience. We had some theory building workshops, so we actually talked to care home staff, care home residents, healthcare professionals, infection preventionists, GPs and nurses working in clinical commissioning. In the third stage, the green ring, we actually again talked to registered nurses in care homes, healthcare assistants, GPs, to actually test our theories out with them and see what they thought about what we'd come up with from the evidence review. And then we had an online stakeholder conference with people to look through what we'd actually come up with in the end. When we looked at the evidence, we found a range of things that sort of, if you like, fit with how we can improve care for older people living in care homes. And if you look on the left of your screen, you'll see, if you like, the fundamentals of care, so the physical needs that are met by carers within that setting. And then on the right-hand side, we've identified specific care strategies that were very much focused on preventing UTI. And then what we've tried to do is link those to the fundamental care needs. So not to say you have to change everything you do, but think about preventing urinary tract infections in the context of how you look after people day in, day out, how you meet their fundamental care needs. So in our evidence synthesis, we identified that improving hydration was really important, managing continence and toileting needs were really important, maintaining hygiene and perineal care, preventing infections, so keeping people safe, and ensuring that treatment, should it be needed, was timely and given at the right time. So this idea that we can prevent urinary tract infection or CORTI, and by recognising it early enough, we can put interventions in place that mean that the resident won't go on to develop a UTI where possible. So what we tried to do was think about the ifs and thens. So this formed part of our theory building process. So here are some 3 examples. If staff are more aware of the importance of hydration and the need to increase opportunities and a choice of drinks, then residents will be supported to drink more fluids. If care home staff are trained to implement evidence-based CORTI interventions, so preventing catheter-associated UTI, incontinence planning and hydration activity, they're actually empowered to challenge requests to catheterise and order urine cultures. So if you like, the mechanism by which these interventions work is that staff become better informed and better able to make the right decisions based on their understanding of what's going on. If there's a common understanding of signs and symptoms of UTI through education, using language that's appropriate for the level of clinical knowledge, then it's likely that appropriate information will be communicated accurately across the care home and healthcare team. So one of the things we found is that often, if you like, the language of care home practitioners and the language of the pharmacists and GPs might be very different, and actually trying to find means by which you can communicate effectively so that the right decisions can be made by GPs is really important. So these are just some examples of how we moved to our findings. So we had 3 key areas that were important in our synthesis. The first is that skilled clinical reasoning, using decision support and active monitoring tools helps you to recognise the chances of UTI early. That using fundamental care and preventative strategies are real priorities for the prevention of UTI and CORTI. And then thirdly, that the leadership within care homes and clinical leadership that's stable and knowledgeable means that best practice can actually be facilitated within those teams. So we had these 9, if you like, aspects of program theory, which are our explanations for why things might work. So the first is that recognition of UTI is informed by skills and clinical reasoning. The second is that decision support tools are important to enable the whole care team to communicate what they're seeing in residents, and for residents' families to communicate that. And the third within that first theory area was that active monitoring is recognised as a legitimate care routine for UTI. So instead of jumping to an immediate conclusion that a resident might have a urinary tract infection, there's this idea that we can actually monitor and put things into place to see if the resident gets better before prescribing something like antimicrobials or antibiotics. The second theory area is about care strategies for residents to prevent UTI, and this is the area that Sophie is going to talk about later on. That hydration is recognised as a care priority for all residents. That actually, in order to do that, you need to drive action to address reduced or under fluid intake. That if someone has an indwelling urinary catheter, infection prevention practices applied appropriately, and that there are strategies in place to recognise and prevent recurrent UTI. Many women in care homes often suffer from recurrent UTIs that could be prevented by particular interventions. And then our third theory area was about making best practice happen. And this focused very much on care home leadership and culture that fostered safe, fundamental care, and the process of developing knowledgeable care teams so that people were empowered to use their knowledge to actually prevent infections within their residential group. So I'm just going to focus on the third bit of the strategies to support early recognition of UTI around active monitoring as a legitimate care routine. You don't need to actually read this because I'm going to go into each of the bits individually, but you can see that this is a CMOC, so a context mechanism outcome configuration, so that way in which we explain what's going on. This is our explanation. So the context factors are to do with the care team, the family carers, the approaches that we put in place, and engagement. The mechanisms are actually the individual resource of within practitioners and externally, but also how they actually respond to those contextual factors. And the outcomes are very much focused on what are we trying to do. We're trying to ensure that we have reduced risk of incorrect UTI diagnosis, and perhaps thinking that UTI is the first thing that appears rather than thinking of other infections or conditions that might be contributing to the resident's particular symptoms at the time. Reduction in inappropriate prescribing of antimicrobials, and also focusing our activity on things which are high value that actually get us where we want to be much more quickly, and that aren't particularly well evidenced within the literature. So in terms of the context, one of the three things that were really important in trying to take this approach for active monitoring is that, if you like, both the care team and the family carers accept that active monitoring is proactive. It's not sitting still and not doing anything. It's very much about what can we do actively to make sure that this particular resident has a UTI, and that's what we need to prevent or treat, rather than jumping to the idea that this is immediately a UTI. And lots of people say, well, we can't sit by and do nothing. But this isn't about doing nothing. It's about watching, documenting, doing things like improving the amount of fluid a resident might be taking in, looking at any cognitive changes that might be aware, making sure that someone is passing urine and those sorts of things. So it is proactive. It's not about sitting back and waiting for things to happen. The second element was a structured approach to active monitoring. You have a protocol that clearly defines what needs to be done and what the criteria might be for escalation. So again, this idea that you're sitting doing nothing, you're not. You're actually looking at what needs to be done, how long you're going to wait, when you might want to escalate it to a GP for them to actually review the resident. And the third element is that residents and family carers are also actively engaged in that, so that they're included in the discussions of the benefits and the risks of different actions, so they understand why the care team are actually taking the approach that they are. So our mechanism bit is that, if you like, the resource, so our care team are actually empowered to engage in active monitoring and evaluate the causes of those non-specific signs and symptoms. So we ensure that they have the knowledge and the skills and the documentation protocols in order to do that. To ensure that the concerns of the resident, any family, and other members of staff are respected, and that we manage expectations through that process of shared decision making. So we have those discussions, we talk about when a decision will be made and on what criteria that will happen. To make sure that there's effective communication between care home staff, residents and family carers and the primary care team, so your GPs, district nurses or others who may be involved in this particular context. And then that care staff understand the actions they should take and when to escalate those concerns about a resident's condition. If you're going through the process of active monitoring, essentially what you're saying is we are going to discuss and update our perspective on this particular resident over the next 12 hours and see where we are then, so that we can actually then take some action, or additional action, should I say. And so our outcomes are very much based on, and we won't jump to conclusions, and we'll have some evidence on which to base our decision making, so that when we talk to the GP, we can say we've actually done this and this and this, and our resident is no better, we think you need to come and see them. That there's a reduced risk of us misdiagnosing UTI for something else, and that if we can do this effectively, that actually we won't have inappropriate prescribing of antimicrobials for that particular resident. And that reduces the impact of antimicrobial resistance, so that if and when they do get a UTI, we're actually able to treat it effectively with normal, if you like, antibiotics, rather than having to resort to some of those that are more protected. So what our review actually identified was that we had to reframe UTI recognition and prevention as part of fundamental care, and prioritize it as part of what people do every day to support residents within care homes. That prioritization needed to filter through to, if you like, regulators and through a system level, so that, if you like, care home staff aren't working in a bubble against what's expected by regulators and the system itself, so that they can do the things easily and they can align with resident-centred approaches. We looked at trying to see how we can integrate the prevention of UTI with diagnostic and antimicrobial stewardship in the care of older people living in care homes, because That's very important. It helps actually to align the expectations of care home practitioners and primary care practitioners, and also perhaps eventually if a resident does have to go to hospital, being able to actually demonstrate what it is that's being done. To look at how tools that are already in existence can be harmonized to ensure that decision and communication is focused on deterioration that needs escalating rather than deterioration that can be managed within the care home without residents having to go to hospital. In terms of other implications for practice, what was quite evident was that a range of expertise is required to help care homes deliver this type of care. That actually there is a real dearth of continence advisors, speech and language therapists that care homes can get access to easily, and so therefore those other professional groups need to be available to the workforce within the residential care setting. But co-creation of improvement initiatives has to involve the whole care team, and Jackie and Nick are actually going to talk about co-creation in the next session. And finally, the issue of, if you like, inequalities in healthcare, that actually this is important to ensure that effective treatment is available to elderly people in the community and those living in care homes in the same way as it may be available to people who are actually in hospital. So ensuring that what we can do for those people is on an equitable basis. And if you're interested, here's some light reading for bedtime tonight, but you will be able to see that on the recording at a later date. So I am now going to stop. And if you have any questions about that, if you would like to pop them in the into the question and answer, that would be helpful. Jackie, I don't know if you want to add anything to what I've just said, because I know we're waiting for Nicola to join us.
Yeah, indeed. Nicola will be with us about 10 to, so there'll be a little bit of a pause, I think. But I think probably all I would say in relation to this is that the process of doing a realist review is really enriched by the high degree of stakeholder engagement throughout. So you really benefit from multiple perspectives and different voices and thoughts around the whole thing from the very start. When you're scoping evidence, we're going to steer about what kind of evidence we need to be looking for, what matters most to people who represent residents in care homes, just so that we didn't lose sight of these as the kind of core elements to look at. And then checking in throughout the course of the review, which was, it felt longer, but it was an 18-month process, wasn't it, Heather, with the sort of direct involvement with doing research. But actually we kept a good, strong engagement going, which means you're inviting input into shaping how our work is progressing and making sure that what matters most to those working and supporting people living in care homes is properly reflected in the evidence, and that their views shape it and are part of the evidence as a whole in a sense. So it's very much real world perspective, and I think that's kind of what sets this apart from a conventional review of evidence. So it's sort of that stakeholder perspective, I think, is key, which is why it feeds quite nicely into the next piece on co-production, I think.
Sophie, I don't know if you have any comments around any of those particular aspects or issues that you want to make at this point in time.
No, I don't think so. No, it's interesting. As you're talking, I'm thinking about you know, what happens in practice in care homes and that kind of business. But yeah, no, interesting. Haven't really got anything to say at the moment.
So, Jackie, I don't know if we can move to the next presentation, or should we give people 5 minutes to have a quick comfort break just while we're waiting?
I think that's a good idea, just so that Nick can join us. I'll drop Nick a line in the meantime.
Okay, thank you.
Okay, we'll make a start and hope Nick joins us in a moment. So thanks for the introduction, Heather. I'm Jackie Prieto, Professor of Nursing and Infection Prevention at University of West London, and co-led the Stop UTI review, and have since had the opportunity to work with Nick and the co-production collective to really look at how we can bring this evidence to life for future use in care homes. And we've had the pleasure of working with Glentworth House Nursing Home in Hove in the UK, who we've worked together with now over the last 18 months to start shaping some of the core messages from the review into a sort of set of principles for practice. So I'll make a start and hopefully Nick will join us. In the spirit of co-production, Nick and I are co-presenting, and she will introduce herself when she joins. We're going to start with a short digital story that was filmed at Glentworth House about their approach to hydration care, and we'll follow that with Nick telling us more about the values and principles of co-production and that guide how we're working together. Nick's joined us, brilliant. And then I'll talk about our rationale for hydration care and progress to date. So actually, as Nick is now here, excellent, here, camera on, off mic. I'm going to hand over to you, Nick. Sorry to catch you on the hoof. We're running slightly ahead of time. So I've introduced myself. I'm going to pass over to you to introduce yourself. Heather is moving the slides on for us, and so once you're ready for the film to start, give Heather the word and she's all ready to go. Lovely, over to you, Nick.
Great, thank you, and hi everyone. So I'm Nick, or Nicola. I am part of something called Co-Production Collective. We are a community or network of people based within University College London who support the co-production of research, services, and also policy. A part of this piece of work, I don't know if you've already mentioned this, Jackie, but yeah, we kind of got involved to help support the co-production of the work we're going to talk to you about today. Yeah, that's probably it from me and who I am. But this, we're about to show you a video that was developed as part of our work with Glentworth House. It's a digital story that really talks about some key elements around hydration for overall health and wellness. It was made for the Vivaldi Social Care Study, and it was funded by the National Institute of Health and Care Research, so NIHR, who has funded actually the entirety of the research project. If we could play the video, please, Heather. Thank you.
Last week, one of our younger residents, Danny, who cannot speak but looks up and blinks for yes, was asked if she wanted to go to a nightclub for her 40th birthday. She looked up and just kept blinking. So we found a venue, and there she was, under the disco lights, leading the conga in her chair. Her smiles said it all. Moments like this remind me why we fight so hard to understand the individual's needs, their likes and dislikes, a favourite TV show, a song, and of course, favourite food or drink.
When Sheila first arrived, they said she only had 6 weeks left. Her pressures were severe, her body tired, barely eating or drinking, her light was fading. But with food and fluids, we built her strength to enjoy an unexpected 18 more months of life. But we don't just give hydration, we give time with it. And if one way doesn't work, we find another. If a straw is too challenging, we try a spoon. If water is rejected, we try juice, or yogurt, or a fortified shake. We get there, little by little, spoon by spoon.
After only a month, Sheila had gained 3 kilos. Her wounds began to heal. She was smiling again, and we, the staff, who had walked with her through every long hour, were smiling too. People ask us, how do we do it? Truth is, there's no manual. Right now we have residents aged 26 to 99. Every story is different, and every resident has individual needs. But one thing is always the same. It takes time. Eating and drinking have always brought people together. Why should that be any different in a care home? We sit with them, we drink with them. Sometimes feeding someone takes an hour, but that hour is often when essential trust is built. It's never us and them, it's us together. Hydration isn't a task, it's a shared moment. We learn what makes each resident feel human again. One man missed having a beer due to swallowing difficulties, so we searched for a special thickener so he could enjoy it safely. Hydration is an opportunity for personalised care, not a chore or a routine. Our chefs make jellies, ice creams, and mocktails. We even hold pub afternoons, and nutrition and hydration becomes fun. Every flavour, every texture is designed to say, you are still here, we see you and hear you.
Back at the nightclub, our birthday girl kept blinking with happiness. We created a gin and tonic flavored foam that melted on her tongue. She couldn't speak, but her joyful shout filled the room. In that moment, she wasn't defined by tubes or limits. She was simply alive, celebrated, and free. And we shouted with her, because here, hydration isn't just food, it's freedom, dignity, and every good reason to keep smiling.
Thank you, Heather. We could go back to the slides.
That's that could be a task. I'll try.
Thank you. We wanted to share that because it's such an amazing reflection of Glentworth in particular, but also the massive importance of actually working with residents in relation to any type of work, residents, people with lived experience, but in this particular case, the residents, and the impact that has had on the way that Glentworth work in terms of hydration. We've got a slide in a minute that just talks about some of the value of working in a co-produced way that I'll talk through. If Heather can make the slides work. Sorry, Heather.
It's trying to share different screens and
we did a piece of research at Co-Production Collective because we often get asked, like, what is the value of working in this way? Why should we bother to co-produce something? And so we did 100 interviews, a survey that was completed by nearly 600 people, and also a systematic review of the evidence. And what we produced is what Heather will share on screen in a moment, is the value of co-production research project. And there were 5 key findings. There should be, don't worry if it's not there. It's the next slide. Sorry, Heather, that's my fault. I got ahead of myself because I didn't have the slides to look at. If we just go to the next one and we'll go back. But so the value of co-production lies in 5 key areas. And I don't think these areas are rocket science, but they are really important that they're captured within research. So co-production delivers outcomes that actually matter to people. It connects us as humans working towards shared goals. And it really helps in working towards social justice, something that we consider, really fundamental. The other thing is that it does empower people and builds capacity or capability. However, that one has a star against it because actually a lot of people, when we were doing this research, said to us, I have all the power I need. I don't need anybody to give me power. What I need is access. Often institutions or organizations block that access, which means I can't get involved in research, in service development. I need that access, and co-production helps provide that. The other one is it provides efficiency in the long run, by which I mean, it takes a little bit longer to get set up and develop relationships as a team, but actually in doing that, we're addressing lots of issues at the start that we may have come up against barriers in relation to later on. But if we address them at the start, we work out how to work together, we can then move forwards more quickly and actually achieve what it is we need to quicker in the long run. If we just go back one slide, I'll just talk briefly then about what co-production means to us. As co-production collective, co-production is about working together in equal partnership for equal benefit. Something that's really easy to say. The reality of that is a lot harder to achieve. And that relies on us living up to kind of 4 key values that we think underpin co-production. The importance of being inclusive and proactively promoting that constantly, thinking about how to be as accessible and inclusive as possible. And that includes working in an anti-discriminatory way. The importance of transparency, so being open and honest about the challenges, talking as a team, and considering everybody, whether their experience is lived or learned, everybody is part of a team. And so we need to be open and honest about what is and isn't working. We all need to be embracing of change. We want to challenge that status quo constantly ask why, and be welcoming of new ideas and ways of working. It does rely on being kind, this way of working. Actually, there can be some really challenging and difficult conversations. There can be some massive roadblocks. But if we can approach it in a way that's kind, we can work through those things together, we can learn together, and we can move forwards. And yeah, that brings me to the final one, the importance of being reflective. A culture of learning embedded in this way of working is vital. We're not going to get it right, and we don't need to get it right. We need to learn, and we need to be open to learning and moving forwards in our practice if we're ever going to come close to working in a genuine co-produced way. And if we could move on, please, Heather. Thank you. So I just wanted to briefly then touch upon the practical kind of reality, I suppose, of co-production. And these are principles from the National Institute of Health and Care Research, so NIHR. They say that the importance in terms of practically working in this way is that you build and maintain relationships. You need these in place in order to co-produce. You need to be able to share power and decision making, the reality of which is difficult to do. If we can build those relationships, we can start to have difficult conversations to understand our own individual power, our positionality, our world view as we come into a space. We need to be able to understand and break that down so that we can make decisions together as a team. It's important that all voices are included, valued, and listened to. So we do need to be very mindful of that, and we need to talk about that as a team. We need to understand what each of us is looking to get out of working together, and we need to make sure we're constantly listening to each other as well. And there does need to be something in it for everybody. It shouldn't just be about what an organization wants out of this and those organizations pulling strings and demanding things of people with lived experience. Actually, there needs to be something in it for everybody. And we need to know what it is that's in it for each of us so that we are mindful of that and we're working together to achieve the outcomes that we're looking to achieve. I think it's over to you, Jackie.
I do believe it is. Thanks, Nick. I think it's fair to say we were as much there to learn from Paul and his team at Glenworth Courts as they were to work with us on the piece of work we were looking to accomplish. So I'm just going to start by talking about the rationale for a hydration charter, as we called it. When we started thinking about how we can communicate and use the findings from Stop UTI, the idea of a one-page summary or charter on hydration care was put forward as a way of sort of saying, here's a standard of what good looks like. But I think, bearing in mind what Nick has said there, it is against the backdrop of knowing that care homes are working hard on this agenda. And certainly when we worked with Glentworth, they weren't starting from a standing start, as you can well see from that video. They were well on their way, and it didn't actually stop them as a care home being very curious and inquisitive about what else might we do to add value to what's already there. But the most important thing for us was to learn from them, hear from them, and see how what they're doing aligns with what we had found through our evidence. And so the kind of thinking was to help care home managers and their staff to focus on what's being accomplished and why it matters, but putting it in the words of staff and the team at Glentworth through their lens rather than necessarily ours, promoting a shared understanding and values around good hydration care. This is what we're looking to communicate more widely. The idea of having one common message, a standard everyone recognises and can sign up to. And it's just on one page, it's at a glance, easily readable summary, so not one that looks like a sort of traditional piece of research where it goes on for pages at a time. It's also about increasing the visibility of project work by engaging staff, residents, family and friends. And so our intention with the Hydration Charter is for it to support work that's happening in care homes to promote hydration, and about making sure that what they're already doing and what they're planning to do is made visible, so they've got ways to talk about that with the residents, with family and friends and others coming into the home. And for us as a research team, it was about bridging the gap between theory and practice and making it real and relatable. So next slide, please, Heather. So as Heather presented earlier, there were some core messages from Stop UTI around a range of different practices to promote the prevention and accurate recognition of urinary tract infection in older people living in care homes. And we were interested here on the core messages relating to hydration care. And there were 6 areas of focus that came from the research. And because of the way that the Realist Review had been undertaken, we were aware that our findings were able to reflect multiple voices and perspectives, including the care home managers and the teams that we engaged with during the research, because we had a high degree of stakeholder engagement throughout. And the areas of focus were around involving the whole care team in making best practice happen. We found evidence on this in relation to hydration care, as well as all of the other strategies that the review encompassed. Oh, that's just gone ahead a little bit prematurely there, Heather. Thank you. The importance of prioritising hydration as a care and social activity, for it to be seen not as a task, as Paul says, as a shared moment, as an opportunity to engage with residents. And I think, in a sense, I mean, that the video says it way better than I can, in an environment where this is clearly happening in a very rich and lively way. Personalising hydration care based on residents' preferences and needs. I mean, who'd have thought you could get a gin and tonic flavoured taste for someone to enjoy on the 40th birthday? I mean, that to me epitomises excellence. And a tricky one around ensuring residents consume enough fluids during the day and helping those with low intake to drink more. And we'll come back to that shortly. But that is, I think, a really challenging aspect of practice for people working in care homes and for the residents themselves. It's not easy to make sure you're drinking enough. Recognising the importance of hydration through effective education, so that the way that learning can be contextualised within day-to-day work, and that care staff can really recognise why this matters and why what they're doing can make a difference. And then involving family and friends in supporting hydration care. So they were the kind of, this was the starting point as far as the hydration principles from the Stop UTI research was concerned. But before we went to that, what we really wanted to do was learn from the Glentworth team about their work. And so before we even got on to the idea of what do you think about a charter, our first couple of meetings were actually about getting to know each other and hearing about the work that happens at Glentworth. So if you could move to the next slide, please, Heather. Thank you. So during our initial meetings with the team at Glentworth, we wanted to learn more about their experiences of what works, what the challenges are as they see, and also opportunities to even further advance what they're already doing. And Paul, as care home manager, to my mind, just demonstrated throughout his commitment to empowering staff and residents, getting everyone involved. He was doing this from the outset, and it was the people he invited to each of the meetings it was very inclusive, and he made a real point of saying this was the ethos in the care home. This is why what they're doing works. They already have a whole care team approach to everything they do at Glentworth House. Paul explained his leadership style as a scene force, shaping culture through consciously modelling the behaviours he wants to inspire in others. And so, as he put it, he's not in the office all day, anything but. He's very much there, visible in the work environment, and there to support. And that's the kind of leadership, that engaged leadership, that there's evidence for coming through very strongly in the Stop UTI review of why this is one of the conditions that needs to be in place for successful implementation of strategies. And there it was, a brilliant visual sort of reminder for us, and for me particularly, seeing how much that resonates with what we learned from research-based evidence. So our initial in-person meetings involved healthcare support workers, the activities coordinator, we had the head chef, we had a couple of student nurses who were on placement, and in the second meeting we were also joined by a resident's husband, and this was Reg, and so his wife Sheila was featured in the film clip we saw. And Reg really added value in those meetings. He really sort of was able to present what a family member's perspective was, and how Sheila's needs were taken account of and needing to be met. So it really did feel as though we had a great team of people that we could learn from. And Nick and the team, the way that it was facilitated really enabled everybody to have opportunities to say something, and something I hadn't even personally recognised. But we started with an icebreaker in every single meeting, and it was a chance for everyone to say something. It wasn't necessarily something to do with the project at the start. It was just, let's hear about your weekend. Let's hear about some particular thing. So everyone had a voice, was listened to, and we were interested, and it was valued. So it created a really nice environment to really start to sort of hear from everybody in the room. And so we were hearing about how initiatives using every opportunity to drink more had been tested out in Glentworth, and they were saying that they have an initiative that's proved quite useful about having a drink every hour. So keeping this something that is very constantly an activity that happens within the care home, and really actively encouraging care staff to sit with a resident and have a drink together. This isn't a task, it is a shared moment. This is work, but it's work that has a whole host of benefits, and so not something that can't be fitted into the day. And certainly we've seen feedback from other evidence about how sometimes care staff will think, oh my goodness, is this okay to sit with a resident and offer them a drink? Should I be doing some other sort of tasks? Will I be kind of picked up for slacking because I'm here helping drinking and I'm even having a drink myself? And that really isn't the ethos at Glentworth House at all. It's quite the opposite, and really emphasising how it's a very social activity as well. Staff can have drinks. There's opportunities to be creative, make it fun, make it social. When we first arrived, our very first session, there was a whole host of drinks, but also fluid-rich foods. We had melon on offer, pineapple, a whole load of food and drink. So we all left fully hydrated when we had our first few meetings there. In relation to personalised assessment of preferences and needs, the team at Glentworth were describing how they made assessments of individuals around their preferences, any special requirements, if they needed thickeners, if they had any swallowing difficulties. They talked about a particular resident for whom they'd ordered a special cup to help with drinking in a way that reduces choking risk. So they were constantly thinking about how can we make things better and more personalised for each of the residents we take care of. Presenting drinks differently. Sheila liked her drinks in the form of a jelly rather than fluid in a cup, and that really did help her stay hydrated. And the other thing they said, that they kept every resident under review insofar as they didn't assume that what somebody liked at one point in time was therefore what they get offered continuously after that. They actually had a resident of the day process where they had 30 residents in the home, and so each day of the month they focus on a different resident just to check in and really look in detail about how are we doing with them. In terms of learning opportunities, there were micro training sessions that they undertook at handover. There was a training manager appointed at Glentworth who gave very tailored support to individual staff according to their learning preferences. Paul undertook a training module on hydration care run by the Care Skills Academy with the idea of just testing it out, what's it like, and then created an expectation that everybody else in the care home also undertook it. They're all chuffed to bits to have certificates for this, and it just set a precedent that this matters to us. We want to learn as much as we can about it. And the emphasis from Paul's perspective was very much on the reasons why hydration care is important, not just telling staff what to do, but making the link that drinking less can be linked to getting an infection or other problematic outcomes. And then involving family and friends. They were mentioning that sometimes family can be reluctant to offer a drink in case they do something wrong, and therefore having the support and having a version of the charter that enabled them to get more involved would be helpful. The other challenge they mentioned was around measuring fluid intake, and I think we know this is a really tricky area in care homes, ensuring that all fluids consumed are recorded. And one of the things they mentioned was that because they have a very active social programme, residents are often taken on trips. They go to the local museum into a cafe, which is lovely, but they're saying sometimes on those occasions they might forget to include what fluid intake they've had during a session like that. They recognise sometimes when they're giving drinks with medication, they may not remember to record that. Ensuring that new staff, including student nurses, know where to record information, and also when visitors are involved in supporting fluid intake, that they know where to record information. They had a system where fluid intake charts were checked every night and then fed back in the morning so that more focus could be paid the following day to residents that weren't drinking quite so well. Next slide, please, Heather. Thank you. So we first of all put a draft in front of them that was a very kind of, you can see, quite wordy. It had the 6 core messages on the left that we framed as care commitments. We had a statement about why hydration matters and a goal for minimum fluid intake for the day, and then also an explanation as to why these different elements are important. And when we got into the detail of what do you think of this, I mean, their immediate reaction is, as you might expect, well, it's too much to read, needs to be visual. Actually, we need a form of this in a booklet for residents and family. And how can we turn this into something using examples that we ourselves can demonstrate how these principles are being met. So on to the next slide. As we were discussing this, and Nadine, one of the care home support workers, who's very creative, and started drawing, and she said, oh, I think I can visualize this. And she was drawing pictures for us just on a blank bit of paper, and out it came. And we since then converted this on Canva to something that represented what it was Nadia, wasn't it? What she had to say. And immediately she just said visual communicates. And we kind of all know this, don't we? But this was a very early contribution that they made, is let's keep this visual. So that was helpful. Next slide, please. So one of the team went on to Canva and converted our original Word doc into something more visual around the principles. We were limited on Canva in terms of the graphics available, so we were kind of aware that the pictures weren't right, but it was just a starting point for comment. And the team at Glentworth appreciated the colour. They liked the fact it was eye-catching, but they said, yeah, still too much to read. Text needs to be bigger. And emphasise how we need a variety of different formats. They said that posters work well for staff. It's really quite good to keep the whole topic alive. They actually quite like putting posters on the back of a toilet door when people have a moment to themselves to take in information. And quite rightly pointed out we need different images. So next slide, please. Because Paul links with all of the area managers in the Brighton and Hove area, he was able to take the hydration draft that we had to meet with his colleagues, and Nick and Julie from the Co-Production Collective joined together in that meeting to just hear a bit more about what other care home managers have to say. And it was great to hear their feedback. They basically said, look, this is useful, it's reasonable, it's a reasonable ask and it's doable. So we can see there's nothing in here that makes us think, oh my goodness, this is off the mark, we can't do this. They appreciated the positive tone. They didn't think the language we were using was patronising. And they said these sorts of things can be really useful to keep hydration at the front of everyone's minds. And what they really emphasised as well was that, look, as care home managers, they get this, they really do. And what they're looking for are ways to help support their teams in engendering a culture where everyone recognises the importance of this and the priority of this, rather than feeling as though somehow it can always compete with other work. But as you can imagine, they also said we need headings only. This is too wordy, needs to be simpler. And so let's think about that. They also echoed the thoughts around let's have a format for different audiences, including families. And we're really saying, could we get a graphic designer to engage with this and draw attention to the key messages and frame them? So next slide, please, Heather. So we're getting there. We are currently working with a graphic designer on this. And in the meantime, in the background, the team at Glentworth are continuing to think about what they're doing, finding new ways to keep hydration as a frequently discussed topic. So they are working that into the way that they deliver their services every day. Filippo, who's on the video, designed a new chart to record not just fluids offered, but the fluids consumed. And we know that certainly it's been a tricky thing in care homes when you record what fluids offered, but you don't always know actually if that is an accurate reflection of what someone had to drink. So they were constantly sort of looking at how they can further develop what they're doing. They recognised that more frequent reviews during the day and a visual reminder might be helpful. So their previous practice of reviewing their charts overnight and then feeding them out the following day, they thought, well, actually, we could do even more here. So they now review these charts more frequently in the day, and they've used this system. They called it, it was referred to as using blue dots, which is a visual cue. So the team were aware of residents who were particularly vulnerable to low intake on that day, and they could respond during the day rather than the following day. And then again, thinking about how they can get family and friends directly involved in recording the drinks that they've been involved in giving. So in terms of next steps, and I'm aware from having started early, we're running late now, and that's my fault. Well, as I said, we're working with the graphic design designer who's helping us to reshape all of this and looking really at using the headings only. And it sounds simple, just putting headings in, but these headings really need to mean something to care. So they have to communicate a message that they can think, we get this, this is what we do, or this is what we're aspiring to. So we're working hard to get those messages framed. So when we have the next draft, it'll go back to the team at Glentworth and it will go to the area managers, and there's other opportunities to gain some more feedback about, is this hitting the mark yet? And then we're going to be developing a version for family and friends, because that's been a repeat ask, which is what we need to do. And then ultimately, we're planning to use the charter, or whatever we decide to call it, as part of a hydration intervention in care homes. And so this is something where we're looking to use this as a way that care teams involved in the trial can see what it is that we're working to. So just final slide, just to say a few thank yous really. Firstly, residents and staff and Glentworth House Nursing Home. It's been a privilege working with them, it still is. We learn loads from them. Just wanted to say thank you as well to Becky McCall, who's the medical journalist and Storybug co-founder. We've got the link there in the slide if you're interested in re-looking at the film that was shown today, but also there's other films there that are great stories. And then thank you to Laura Shallcross and the Co-Production Collective. And this work was funded under Laura's research professorship as part of the Vivaldi study. And we've obviously had the pleasure of working together with the Co-Production Collective to deliver this project. So I think that's us finished. Did you want to add anything at this point, Nick, before we finish?
No, just to say thank you very much to everybody who's listened, and to you, Jackie, as well. Great working together. So.
Indeed. Thanks, Nick.
Nick, I know you've got to go. I wonder if you've got a couple of minutes just for some questions to
that's fine
before we let you disappear. I'm very taken by the idea of the amount of time. I mean, what Jackie has presented in terms of where you've got to so far with this particular initiative, but it does seem that time is a real is a real issue, both for practitioners, but also perhaps for people who are wanting to get their message into the ether quickly. How much time does it actually take for these things? Is it an extensive period of time?
These things being co-production,
yes, co-production and getting, if you like, getting to the end. So I mean, for example, the film that you showed, what length of time did that take to actually, if you like, write the storyboard? I know the production itself might have taken time, but if you like, to get the components right.
I don't actually think it took that long to make the video. I'm trying to think. I think they had a couple of meetings with Becky, Paul, and Filippo, and she came to the care home and had a look round, and they captured some images and things. I don't think that took very long at all. I guess to answer your other question, how long does co-production take? How long does working as a team take? You know, it's all about what you're trying to produce, isn't it? And I think that what's more important when it comes to co-production is actually that everybody is sharing a set of values and that they're upholding those values in the way that they're working together. And so, you know, you end up in a lot of situations where it's kind of like a research team with some people with lived experience tacked on the side, and they never become central to the team, to the decision making. And that's the thing that you've got to break down if you're going to come close to co-producing something, is that us and them situation. We're all teammates, we're all one team. It doesn't matter whether I come in with lived experience and Jackie comes in with her academic and clinical experience. All types of experience are valued equally. And that's the thing you've got to break down. But there's so many thousands of years of like system kind of structures and people being taught to behave in a certain way that you have to break down. And that's where the power kind of situations come in and where you've got to address those differentials. So for me, that's the key element that, yes, can take time to break those things down, right? But it's less about how long the work takes to do and more about how embracing or not the people in the room are of that kind of culture of openness and learning and development.
And so in your role, is that part of, you know, your real focus, is, if you like, getting people in the room to recognize each other's value and looking at that approach to proper partnership? It's a little bit, isn't it, like having lay members on a research team. They're often there but may not actually be part of the research team in reality, whereas actually becoming a real member of a research team is really important from your perspective. So
yeah, absolutely. And it's also about supporting a team to work in an anti-discriminatory way, to genuinely understand what that means and to genuinely break down those barriers that are causing people with lived experience to be part of a meeting but never say anything because they don't feel able, because either they think they will get kind of ignored or walked over by those that have seemingly or appear to have more knowledge and experience and power, basically. But actually, you've got to be really aware of, if you take racism, for instance, it's not enough to say, I am not racist. You need to be actually actively anti-racist. And that means delving deep into the structures and the systems that are set up in a certain way and unpicking those. And the same applies to any kind of form of anti-discriminatory practice. We have to delve deeper underneath those things. And it's not okay just to say, oh, well, anybody can speak when you want to. It's much deeper than that. We have to understand why we don't feel comfortable in a space. People are using jargon, acronyms, organizational speak. They're going off on a tangent about a particular research arm that nobody understands unless you're that researcher, for instance. And so you've got to break all of those things down and kind of rebuild them in a way that you can all work together.
Yeah, brilliant. Thank you very much, and thank you for your time this afternoon. It's been fascinating listening to what's happening at Glentworth and your role. So thank you very much indeed. So we are a little bit now behind, but we do have quite an extensive amount of time for questions at the end, so I don't think that's too problematic. So I think we'll just take 10 minutes here to have a comfort break, and then we'll come back to listen to Sophie's presentation about her implementation of a hydration intervention in care homes. So if we could come back at 14:50, so 2:50, 10 to 3, that would be great. Thank you very much indeed. Right. Hi, Sophie. Okay. So if I introduce you to Sophie Corbett again. Sophie is a registered manager of Care Plus and has implemented a programme of work to improve outcome for residents in relation to hydration and preventing unnecessary hospital admission for urinary tract infections. Thank you very much, Sophie, for presenting today, and over to you.
Thank you very much. It's quite interesting listening to what Jackie was talking about in relation to co-production, because this is what I'm going to talk about is completely the sort of the other end, really. It's taking up the problem of UTI hospital admissions and applying a bit of a kind of quite a top-down approach to the problem. I worked on a project commissioned by the ICB in Shropshire, Telford and Wrekin for a couple of years, and it was to do with trying to reduce hospital admissions from care homes due to UTIs. So the nature of the situation is that UTIs are quite often the leading cause of hospital admissions from care homes. So this is our Shropshire, Telford and Wrekin position 2022-23. And as you can see, UTIs and lobar pneumonia are pretty well neck and neck in relation to hospital admissions. It's kind of harder to reduce chest infection related hospital admissions potentially from care homes, but UTIs very directly can be reduced if you improve hydration. And sepsis there is the fourth leading cause of hospital admission, and 30% of those, 20 to 30% of those will be a UTI cause. So if you can reduce UTIs, UTIs and UTI hospital admissions, you can massively reduce overall hospital admissions from care homes. And the average length of stay in Shropshire during that period of time was 11 days. So it's quite a substantial hospital admission. And as we know, there's a big impact on mobility and increases in frailty and everything if you have a hospital stay and spend a lot of time in bed. Anyway, so my project, it was called the Clinical Practice Education Project, funded by the ICB, and the aim was to reduce unnecessary hospital admissions due to UTIs. So thank you. Next one. So the first thing is really, are people in hospital, in care homes dehydrated? And this was a nice bit of research by Hooper and co in 2016. So of course, at the beginning of the project, I was looking at all the literature and the research that was out there. And it, if you want a kind of a good statistic, I mean, it seems to be that 20% of people in a care home will be dehydrated at any one time, with another 28% at risk of dehydration. And they might become dehydrated if you were short of staff, or if the weather was hot, or any of those other kind of situations. And only about 50% reliably would you say well hydrated. So I always think that's quite a good thing to talk about with care home staff. If they're a little bit skeptical and they say, oh no, don't believe it or whatever, it's always good to talk about the stats. So going back one, so the Clinical Practice Education Project, we worked with 20 care homes, which is 12% of all the care homes in Shropshire, Telford and Wrekin. I don't know where our people on the webinar are, but if you don't know where Shropshire is, that is where it is on the map. It's a very rural county. And anyway, so we worked with 20 care homes and a potential impact on approximately 1,800 residents. And it was a proof of concept project. So the idea was, so I was given this as a project. I didn't decide that this was either good or bad, but the idea was to test a whole home training approach, and was it acceptable and feasible within care home environments. And a whole home training approach is to train as many people as possible in the care home. So Jackie was talking earlier about the importance of involving cooks activity coordinators, and all staff in a care home, not only the carers and the nurses. And this is what we're talking about. So the training was training for the kitchen staff, very important, activity coordinators, very important, but also maintenance potentially, or the cleaners. Cleaners are often going in and out of people's rooms, hanging up laundry, and they might very much be in a position to, I should go back one, Heather, please, go back again. Very much in a position to kind of prompt somebody to have a drink or have a chat to them about their drink and this sort of thing. So I set the target really of training 85% of all the carers and nurses in each of these care homes, and involving those other staff as well. And then the other part of this proof of concept project was, does intensive training on hydration and UTIs reduce hospital admissions? So intensive training, it was quite time consuming. I went back many times to the same care homes. Some care homes had up to 12 sessions on hydration, and overall I did 100 sessions of the training. Right, next one. So I developed a training session, and actually I was really grateful to Heather and all her team at the University of West London, because I'm going to show you a picture of the resource in a minute, but they produced this hydration in care homes pack, and it was based on all of the work they did with care homes, and there were a lot of really useful training resources. So my training session, which lasted an hour and a half, which actually was probably the limit of what your average care home can kind of accommodate in terms of a training session, included some background stats, what's happening locally in Shropshire, what's happening in care homes, like that 20% of people in care homes are generally hydrated, that kind of thing, dehydrated. And then we had a quiz, and then we talked about the effect of dehydration on older people, and then we talked about good practice. And the more sessions I did, the more I was able to incorporate stories from all the care homes that they were feeding to me as I went along. So every care home, they would tell me a little bit about what they were, little anecdotes about what was going on there. So that really added to the richness of the training, I thought, actually. Okay, thank you. So here we go. If anyone is thinking about doing any training on hydration in care homes, I would really recommend this practical resource pack. It's excellent. It's got loads of good ideas. I used that hydration quiz as the Kickstarter for the training. Very good for establishing, what people's basic knowledge about hydration. For example, the first question is how much should people be drinking? Often people don't know that you should be drinking, aiming for 1,500 mils for anyone really, but older people in care homes, they should be drinking 1,500 mils, and you should drink more if you're more active and all this kind of thing. But often that's a lot more than people imagine. But there are lots of good questions in there. What happens to your sense of thirst as you get older? Well, it decreases. The chances are, if you're old, you won't feel thirsty. So I always used to talk about my father when we talked about that question, because my father would always say, I've got to 87, only drinking when I'm thirsty, and I'm not thirsty now, I don't want to drink. So, it was, thirst is thirst. You might as well rule it out as an indicator of whether or not you need to drink in older age. The other thing, they have questions on taste. They have questions on what constitutes fluid, and all that kind of business. So really, really good. If you want to just kickstart the conversation about hydration in the care home, really recommend that quiz. Thank you. Next one. There are a couple of deeply held myths in care homes that I think are always important to address during training, and one of those is that dark offensive urine and confusion is a UTI. And I think I'd like to think that gradually people don't believe this anymore, but during all the training I did, this was very commonly held across all care homes. And what happens then is, if you've got dark concentrated urine, before you know it, the request has gone to the GP for antibiotics, and someone's on antibiotics. And I used to say to staff, look, if you had dark concentrated urine yourself, you wouldn't be thinking you had a UTI. So it's no different for an old person. but also understanding that if you are dehydrated in a care home, it's you can become confused, and confusion, if someone's confused and it's a new symptom, the first thing you should think is, are they dehydrated? So that was a really important key message for training, because if you want people to implement different hydration practices, they've got to understand that people are already dehydrated and know what they're looking for. And the other one is, I had a little kind of poster showing the color of urine, and a little kind of rhyme that would say 1, 2, 3 healthy pee, 7 to 8 you must hydrate, and it corresponded with the color of the urine. So you've got to get that message across, otherwise they won't get it, because then that's very practical. When you go to a resident and they've got smelly urine, you then think, okay, they're dehydrated. So that was that. So this little poster on the left was another poster that came out of the hydration resources in that pack that I was talking about. So routine in care homes is really important. It's your foundation of good practice. It's basically making sure that people are not only offered a drink, but woken to have the drink at the times when the trolley comes around, or at the time when the offer comes around. There's also a very nice little case study, which I used in the training, called Dolly. And basically, this is a very typical care home resident. She's asleep a lot of the time, and she becomes so dehydrated. And one of the reasons possibly she's sleepy is because she's dehydrated, but also the staff weren't waking her for a drink. So showing people that actually you have your routine. Every care home has a routine, but where it goes wrong is that people aren't being woken for a drink, or they aren't being supported to have a drink during those periods of time. And if you get that right, so you're talking 1,500 mils. 1,500 mils is roughly 7 drinks. If you get 1 drink into a person during each of those occasions, you're pretty well there with your hydration. So it's not kind of complicated. It's using the opportunities that you already have and making them work for you. The other quite good tip, actually, is the one around offering a hot and cold drink, because often people won't want to drink a lot in one go. But if you make the offer more appealing through having, let's say, every meal time you have, a cup of tea at breakfast, and you might have a little glass of orange juice. You can make your amalgamated drink, i.e. 150 mils, 200 mils out of the 2 drinks. So that is that. And the preferred drink, fresh jug of preferred drink in every room. I mean, there was one home, interestingly, and it was almost like the most simple but useful change that we made in that home through the training, was that they hadn't got jugs of drink in rooms. And it was because I think they had quite a lot of people with dementia, and perhaps they had a situation where people wandered around and spilt the drinks, and so they just blanket banned the jugs in the rooms. And we had discussions about, actually, maybe you can just not put the jugs in the rooms where people might do that, but everyone else has a jug. And that's kind of fundamental, because with hydration, you've got to take away the barriers to drinking. And if somebody is in a room and a carer has to go elsewhere to get a drink to top them up, they're much less likely to top them up. Whereas, having a drink in the room is like the first step in reducing that barrier. So thank you. And obviously a drink always within reach. So as I went along with my training, I encouraged homes to send me in pictures of what they were doing that was kind of good practice and that they were quite pleased with. So this was a care home that had a great trolley. I mean, the significance of the trolley in improving hydration is not to be underestimated. I became such a, champion for trolleys, because trolleys enable you to have all the choice on them, and you can go around to every room. It removes barriers to residents having a range of choices of drinks, and this, that, and the other. So this is a nice example of a trolley with some hydrating food on it. It's got the significance of the blue bowls is that if you've got dementia, you need to have a contrasting colour plate or cup or whatever, and then the food inside it, and you can see what you're doing. They cut up the fruit in a nice way so that people can have that as finger food, and they can just work their way through it quite nicely and slowly. If that's what they want to do, they can be more independent. So there's a lot, this one slide enabled me to touch on a lot of options, not just hydrating food and how you can be really add to someone's hydration by incorporating hydrating food, but also the visual, the supporting independence, and having a range of options available. It was a really useful slide. And also I did find that when I was talking to care homes, I mean, the reason they were on the project was anyway they had higher numbers of hospital admissions compared to other care homes, so they were slightly motivated by feeling that they needed to improve. But I mean, there's nothing like showing them what another care home is doing to make them think, oh God, if they can do it, well, maybe we can do it as well. You know, that little bit of local competition, I thought it did actually work for motivating them during training. Thanks, Heather. So this is, honestly, I watched this about 100 times, this particular video. So it's again produced by the iHydrate team. It's a really nice one for talking about, there are 4 videos as part of that project, and they're all available online. But this one you know, when you're doing training, it's good to have a range of teaching bits and bobs. You know, the quiz is great, the video is great, a bit of talk and chalk or whatever is great, and a little bit of group work is great, everything. So this was the video option. Found it very useful. It talked about, it's got this lady here talking about how her mother's tastes and preferences had changed, and how she needed such a lot of time to support her with drinking and this kind of business. And I found it very useful to kickstart the conversation about offering choices to residents. It lasts about 3 minutes. Thanks. So we talked in the training about flavors. It's very important. You know, this is so not to be underestimated. You know, so many people in care homes, I think, get offered very basic range of drinks, and we know that as you get older, as I said earlier, you're well, yeah, you lose your sense of thirst, but actually also what happens is you lose most of your taste buds, and this is an important concept if you're wanting to persuade people about the importance of a range of different drinks. You can't taste in the way that you used to. So you're wanting tastes that are going to grab you a bit more. You need tastes that are sweeter. So a lot of people want more and more sugar in their tea, for example, than previously. You want tangy flavors. Dandelion and burdock, Vimto, really popular because you can taste them. So so this is a really important concept, that people won't drink if it's not enjoyable, and to make it enjoyable, they've got to kind of have a sensation of it. And if you can't give them the sensation through the taste, the other thing is the temperature of the drink. So have drinks with ice, for example, or the fizziness of the drink. So fizzy drinks are really well known to be very much more appealing in older age. You can feel that if you can't taste it, you can feel it in your mouth. And also we associate good times with fizzy drinks. And so you've got the two things working on you there. And if you're older, often fizzy drinks are associated with a treat or a sense of occasion. So fizzy drinks are really popular. Lemonade, I mean, that should be just standard on every care home drink, surely. I like this. So I aimed for a couple of hydration champions per home. It's quite difficult to sustain change, but if you can get a couple of people to be excited about the idea of hydration in the care home and to commit to doing a bit more work on it, then I think it stands a bit more of a chance of being sustained. And the hydration champions were great for sending me in photos. So these hydration champions in this care home in Telford, they sent me this picture, and you see the little drinks menu behind. That was another suggestion from the iHydrate team. And their little quote was, "We have a new resident who was unable to express her likes and dislikes, so we made up a few tasters for her." And I thought that was really nice. You know, you sometimes got to start from scratch with people. It's very easy to just, very easy in care homes just to keep giving people cups of tea, because when they come into the care home, somebody might say, oh, they love drinking tea. And they just always take a couple of sips and then leave it. And I would say to people in training, if someone is just taking a couple of sips and leaving it, don't accept that as being okay. You've got to think, okay, maybe we just just because their relatives said they like tea doesn't mean to say they're going to carry on liking tea forever. We've got to think more imaginatively of what they might like and what have we got on offer, and let's see what they like. So I like that. Visual prompts. You know, people aren't thirsty and they've got perhaps dementia, so they're not going to remember that they haven't drunk for the last however many hours. So if you don't have drinks around, people just won't think about drinking. And going back to barriers, if you've got a hydration station, I mean, I have one in my care now. It really helps to enable you to just give drinks in the lounge when people are taking part in an activity, for example. We've got a little hydration station, very easy just to go to it, pour some drinks, everyone has a drink. So visual prompts really important. And visibility. So I talked about the blue plates earlier, but we underestimate how people can't have a difficulty with contrast sensitivity when they have dementia, and also a lot of conditions of eyesight make it harder. So it's much easier to have a high contrast cup. I looked into the research behind this actually. If you have a high contrast dark red or dark blue cup, if it's dark red, your intake of fluid is increased by 80%, and if it's dark blue, by about 50%. So it can make quite a big difference what the color of your cup is. So that's very significant. And also the cup itself. So I haven't got it here, but in the iHydrate resources, they have exercises where you can get residents to try out different cups. What do they like? What's easier for them? What do they enjoy drinking out of? And I think it's really worth thinking, can our residents use the cups that we give them? Quite often, you've got a little cup and a tiny little handle, and it's quite heavy and you can't get your finger through the handle, and very difficult if you've got arthritis or you're feeling quite weak. But having said that, you shouldn't go completely plastic, because a lot of people don't like drinking out of plastic cups, and you have to have a range. So how do we get on? Okay, so I had aimed to train 85% of all the nurses and carers in all these homes, and in the end it was 69%. But it was quite well accepted. There was a good, the homes themselves, again, bearing in mind, as I said, they were quite motivated because they knew that they had the higher number of hospital admissions in the county, but they did accept the training. In general, all homes needed to improve around taking account of people's preferences and also appropriate drinking vessels. All the homes were pretty weak around that at the start of the project. Did we reduce UTIs? Well, here we've got one little column showing all the number of UTI hospital admissions from all the homes in Shropshire. So bearing in mind there are roughly 170 care homes in Shropshire. So this was approximately 150 homes. At the start, they had 60 hospital admissions, UTIs. And then you had, well, here it's 90 project homes. I think one dropped out. 33 admissions from those 19 homes between April and September. So they had really much higher rates of UTI hospital admission. But through the training, their reduction was 36% overall. And compared to there was a reduction in all the other homes of 25%. So it felt like a significant reduction in the care homes that we were working in. Thanks, Heather. Next one.
The button's disappeared. There you go.
Okay. However, there was the other impact of the project that really hadn't been part of what we were looking at in the beginning. Well, we were looking at it. I was gathering data from all the care homes as we went along month by month on the number of UTIs, UTI hospital admissions, and also falls and hospital admissions. And the falls part of it was really interesting, actually, because through improving hydration, you can really significantly reduce the number of falls in care homes. So at the start of the project, each home had an average of 11.8 falls per month. By the end of the project, this had dropped to 8.9 falls per month, which was a drop of 25%. In the care home I'm working at the moment, actually, it was very hot last week, wasn't it? We had, there was a lady, she'd never fallen before. She fell twice in the same day. If you can, it's really, really massive. And if you can keep people hydrated, you're much more likely to keep them on their feet. You become quite dizzy if you're dehydrated. So I'm now a manager of a care home, and it's quite interesting trying some of these things out in practice. And of course, as you're saying, it very much, you do need a manager who is who understands about hydration and the significance of good hydration in the residents, because without that, actually, you don't sustain change, and you're relying on, you know, little groups of people within a care home to kind of know it and be motivated, and that's quite difficult. So what works? Giving responsibility to kitchen staff for choices. So having an expectation that there are always choices in the dining room and on the trolley going around. And this is the trolley from the care home, so it's good. We've got smoothies for the residents who are nutritionally vulnerable. We've got some snacks, and we've got fruit salad, and we've got juices and this kind of thing. So there are different options. And motivating kitchen staff, so training the kitchen staff, having them very much equal partners in the whole endeavour to improve hydration is really important. I did training for all the team, so they've all had the 1.5 hour training on hydration, and this is part now of induction. So when you join the care home, I'll repeat the training for them, you know, little groups as we go along. You know, I was really mortified. We did have one resident who became very dehydrated last year and was admitted to hospital. She's a very tiny lady, and I felt really mortified because I thought, God, this is a care home where I've done the hydration training. I'm really motivated. We still had a hospital admission. You know, it was a hot day, her blood pressure dropped very low, and she was, you know, very drowsy. So, you know, even in a care home where staff are getting trained and you've got a motivated manager, it doesn't always mean that you get it right all the time. Anyway, invest in a range of drinking vessels that support different people's needs. Leadership for sustainability. You need a great trolley. You need the trolley to go around regularly. You need, and through the trolley, you can support people's choices throughout the day. So, you know, whatever you want to drink, it's available either on the trolley or in the home. And the expectation is you should be able to have what you want to drink. And then the hydration station, which I have mentioned already, hydration stations, so that you're removing the barriers and the drinks are visible. What I haven't found worked to get to work so well, and it's something that I know it would be great practice, is the drinks menu. And this was something that was very promoted as part of within the iHydrate resources. If you've got a drinks menu, so let's say, for example, you're going around with a trolley and you say to the resident, what would you like to drink? And the resident says, oh God, I don't know what you've got. And you say, well, we've got tea, coffee, hot chocolate, Bovril, Ovaltine, Horlicks, juice, and the resident is completely bamboozled and doesn't know what you're talking about. So that's where you need the picture menu, and it's a very good way of supporting choices because the resident can see the pictures and take an opportunity to choose through looking at the pictures rather than trying to understand what somebody is saying when they give you a long menu of drinks verbally. So I'd love to think that possibly I can return to the drinks menu and get that to work, but there are these little issues to do with it goes missing or it gets forgotten, people forget to take it out, and it's a bit time consuming showing it to people, and etc. etc. So I'm not saying I wouldn't come back to it because I do know it's good practice, but at the moment I found it harder to make that work. So there we are, that is it. So I'd like to thank Partners in Care. So Partners in Care were the host organisation. I was working with them on the implementation of that project. And also very much like to thank all the people at the University of West of London for those iHydrate project resources, which were really useful. And there we go.
Thank you, Sophie. Thank you very much. And it's great to know that they were useful. I've got a couple of questions. I don't know, we seem to have reduced in numbers of people as we've gone along in the afternoon, but it would be good if Anosha and Antonella had any questions, they could let us know. I was just quite keen to understand how you talked about choice being something, and I just wondered how things like people's cultural backgrounds change the choices that you might offer in a care home, and whether or not that came through. So, for example, I don't know, you might like mint tea or chai, or you might have no idea what pomegranate juice is, or even things like hot chocolate. I wondered how those sorts of things were were taken into account in some of the care homes you worked with.
I don't know. It's an interesting question. I think that it didn't really, it wasn't something that came up as a cultural issue, but if people, the thing would be to just try and know what people wanted to drink and to accommodate that, whatever it was. Peppermint tea, herbal tea, quite an easy, actually, herbal tea, we used to talk about the role of activity coordinators, for example, and how older people might never have come old. I mean, predominantly, we're talking older people in the care homes that I was working with. Older people might never have come across herbal tea. So an activity coordinator activity might involve tasting different teas and seeing what people liked.
Okay. And Jackie was, so I think Antonella said, were there any resulting referrals to speech and language therapy through encouraging increased hydration and the associated elements? And Anosha wants to know, why are drinks choices a challenge? Is it due to budgets?
Drinks choices aren't a challenge, actually. I think it's just that staff maybe haven't been used to thinking about that in that way. They might be challenged in some homes. We found our residents were loving apple juice and getting through gallons of it, but and that could potentially prove expensive. But no, I think it's just that they weren't being asked the question. Sometimes aren't being asked the question about what they want to drink, and it just potentially is a bit more of an effort to have all the drinks available, all those drinks on the trolley. So that's the challenge, really.
And Antonella,
referrals.
Yeah, just through, if you like, the increased observation around whether people were able to drink, were drinking. Did you actually find that people were being referred to salt, perhaps because people had observed that they were finding it difficult to drink normal fluids, that sort of thing?
No, because I think you'd know that anyway. What we did sometimes talk about in training was how you can thicken some of these drinks, and so there's been some research around what are acceptable thickened drinks, and hot chocolate, for example, is quite was quite enjoyed as a thickened drink. Ginger beer, very good as a thickened drink, although you have to be a little bit careful with thickening anything fizzy because it can explode. But no one enjoys a thickened cup of tea. So yeah. So actually, if you are on thickened fluids, the issue is, well, you might be even more likely to not like to drink.
I think one of the things we found when we were doing the project was actually no one knew what thickened fluids actually tasted like. And when we did those exercises with staff, they could see why people wouldn't drink them, what the real issues were. And also another thing that came through, which Antonella's just picked up, was, people are often very protective, saying, well, they can't have too much sugar.
Yeah.
So quite a lot of the fizzy drinks, for example, may have a high sugar content. Was that an issue at all?
Yes, it's interesting because in that quiz right at the beginning, there are in that, what are good drinks to have? I can't remember exactly how the question is worded, but fizzy drinks often came up as being something that people kind of didn't count as a hydrating drink, and it was an opportunity to talk about the role of a fizzy drink in helping hydration. But you can have You can have a sugar-free. Most drinks are actually a lot of fizzy drinks are sugar-free these days. But then you've got the other thing, which is, okay, so for a lot of older people, for diabetics, you don't necessarily want a sugary drink, but for an awful lot of people in a care home, you might be trying to make every sip count, and therefore you might really be thinking more along the lines of, okay, how many calories can I get into this drink? So it's not really about sugar always.
Okay. Jackie, did you have anything you wanted to raise?
I did, Sophie. That was absolutely fascinating. Thank you. Resonates a lot with the research we've undertaken too. So it's good to sort of see how that goes full circle. I was really fascinated with the myth busting and how you sort of worked with staff to help them see the value in what they're doing. And so you're talking about how you wanted to move towards a shift in thinking that dark urine and confusion signifies dehydration more likely than UTI, which is a considerable shift in thinking. It's sort of, how do you unlock that in people's minds if this is an association they've come to sort of make and that makes sense to them? It's you're having to support them to unlearn something to grasp something different. And how did you find that during training?
Yeah, it was interesting because you can see people's scales falling from people's eyes in a way as you talk about it, because you can't get them to think without making them realize without making them understand that in the beginning, they can't kind of understand why they need to improve hydration. Do you know what I mean? The other thing actually was the link between time. So I did this little equation. So you've got most residents in a care home will have E. coli in their bladder anyway. So 50% of people anyway will have E. coli in their bladder, bacteria in their bladder, and 100% of people with a catheter will have E. coli in their bladder. So therefore, there's no point in doing a urine dipstick, for example. And so I showed a little picture of the male and female anatomy and how basically we talked about basically everyone with a pad will end up with E. coli in their bladder. And, as you get old, you can't wipe front to back very well because you can't do that movement where you twist around and wipe front to back. So the chances are old people wipe back to front and they introduce E. coli into their bladders. So from that, I had a little picture of the, like a bladder with E. coli in it. So you've got your UTI equation is E. coli plus time equals a UTI. So we can't influence the fact that you've got E. coli in your bladder because you wipe back to front and because, etc., you're wearing pads and you're going to get colonized in that way. All you can influence is the amount of time that E. coli stays in your bladder. And this is where the hydration part of it comes in, because the more you flush your bladder with fluid and urinate, the more you reduce your risks. And then I would talk about the other people who get a lot of UTIs, which is young sexually active women. And the reason they get, everyone would always slightly sit up and look coy when I would say that, but I would, basically the reason young sexually active women get UTIs is because during sex it's very easy for a bit of E. coli to get in the bladder, and the mistake young people make. And then I would always, compare me, postmenopausal women, and how I can't sleep for more than about 2 hours in a stretch, with your average 18-year-old who can sleep 14 hours without waking up. If you go to sleep having had sex without doing a wee, you wake up, you've got a UTI. It's in a way the same sort of thing. It's if you've got E. coli in your bladder, but then you're not flushing it out, you've got the UTI. And so with the hydration, what you're trying to get is regular flushing. So you've got the mood effect through being well hydrated. You're less confused, you're going to be less dizzy. But the whole business with the hydration and preventing the UTIs is in flushing the bladder. So that's the benefit for the UTI prevention in terms of hydration. But yeah, I always found that was they quite enjoyed that part of thinking about why they needed to drink a lot. And I was going to say, you've got you're talking to loads of people who potentially have teenage kids, and I would say, just if you've got a youngster in your household who's getting a lot of UTIs, and just ask them whether they do a wee after sex.
You were able to demonstrate the impact on falls, and so reduced falls, and making the link between active prevention strategies, and reducing sort of, negative outcomes is an important one, isn't it? And it's quite hard sometimes to demonstrate that we've got reduced UTIs as a result of improved efforts with hydration. Was that something that you saw in care homes at all, or were they able to start appreciating all the different benefits from improved hydration?
Yes, well, every month I would feedback. I would get the data from them. They as part of the project, they agreed to give me the data on the UTIs and the falls, and I would feed it back to them in little kind of bar charts, so they could over time. I tried to tailor it very much for the care home, so over time they could see their own improvements actually, and that felt quite important for kind of making them believe, working kind of, I suppose, with the managers and helping them to feel that it was worth sustaining, because they could see that they'd had fewer admissions and fewer falls.
And was there any impact at all on UTI? I know it's a more complicated one because it's more effective on prescribing necessarily than...
Yeah. Yes, no, absolutely. There was that 36% reduction in the hospital admissions due to UTIs, comparing the first 6 months of the project. No, what did I do? What did the table say? April 22 to September 22, April 23 to September 23. Was that what it said? I think I can't remember. But yes, there was a 36% reduction in UTI hospital admission from those care homes that took part in the project.
That's quite an interesting reduction as well over that particular part of the year, because often, I mean, the reason we did the iHydrate project was because there was an observation that there were greater admissions for UTI during the summer months, and so that time of year is quite a good one to actually measure if you're able to sort of think about it. Could I ask you about, so that the point we talked about, which was earlier on, which was about sort of thinking about time. So actually, not immediately rushing to a diagnosis, if you like, in your head of UTI, and being able to put interventions in before you bring in primary care practitioners. Is that something that as a care home manager you're able to do? Do you have this sort of approach to being able to wait and see what happens, having put some putting interventions in place without escalating it immediately?
Yeah, there was a very good UTI assessment tool in Shropshire, and it did very much encourage the consideration of symptoms. And the idea was, unless you had 4 symptoms, proper symptoms, you shouldn't be contacting the doctor at all. So yes, I did. So the hydration session was the 1.5 hour, and then I encouraged care homes, certainly the nurses, to do an extra hour, which was just a prevention UTI one, and introduce that UTI assessment tool to them to help them with better assessment of symptoms. And we're using that in the care home. It's nice and easy. It's you should have some sort of systematic change, i.e. temperature or new onset of confusion or agitation, and then some other symptom like pain or burning sensation, or it's quite good. And so nowhere on that chart did it say what's the color of the urine.
Is that the target tool? Is it the target suite of resources?
It might be. I'm sure it's being used in a similar way elsewhere. I mean, Shropshire had this tool that they had on the go for quite a while. When I started this project, most homes weren't using it, and I think COVID came along. I think that they'd been trying to roll out this tool through care homes before COVID, and then everything kind of got lost. So I was reintroducing it in a way. So it was using a tool that already in theory was being used in Shropshire, but in fact wasn't really. And it was just reintroducing that. And it's just a good basic tool, really helps with assessment of symptoms, and does encourage you to not do anything unless you've got a really good reason. And supports, you were talking about working with families. I mean, having a tool which you can fill in and then go to a family and say, look, I know you're worried about UTI, but actually I have assessed, here you go, this is what I've filled in this little tool, and here it says, you know, do not contact the doctor unless you've ticked 3 or 4 symptoms on this particular tool. And then the family, like you say, they know that you're doing something, you haven't just ignored it. And you know, it does strengthen the nurse or the carer situation, because they feel very under pressure sometimes. You know, that carers would say, oh, especially in a residential home, oh God, the family, something, they're confused or drowsy, the family want me to dip the urine. I mean, God, no one should be dipping urine in a care home under the age of 60, or they want me to contact the GP. Do you know what I mean? And they felt really under pressure, but the tool was very helpful. It supported them.
And when you've done that, I'm assuming that there is this sort of time when you actively monitor them, and you do say, well, okay, let's increase the amount of fluid this particular resident's having. Let's actually look at this and see whether or not the confusion, for example, disappears. And it may not be a UTI, but we may need someone to come and look at that person because it might be something else.
Yeah.
Okay.
The question from Antonella in the chat, I think is a really good one, about the challenge that care staff can face if a resident is worried about not getting to the toilet in time, and therefore is deliberately not having as much to drink because they're worried about their independence and getting to the toilet. Is that something that you've encountered?
Yes, absolutely. And actually, often it's particularly at night. And I would say in training that if you have a resident who starts limiting their fluid intake from 4 p.m, let's say, because they don't want to be incontinent and I or getting up, that you've got to work even harder to get the fluid into them earlier on in the day. And that's but yeah, I mean, it's when you're talking about hydration, this is massive, because there are loads of reasons why people don't want to drink. So that is one. It's painful, actually, perhaps having to get to stand up. You've got to be quite motivated to actually drink, because you know it's going to be a monumental kind of effort to get to the bathroom, or you're going to be incontinent. And yeah, so all these are important things to acknowledge at the start of the training. When it comes to, okay, what barriers? You've got to understand the barriers in your resident. So if that's the barrier in that resident, then actually it really helps to think, okay, yeah, let's try and get them to drink more earlier on in the day, or let's have a conversation with them about incontinence and what can we do. Or yeah, it is a good question, and you have to understand the barriers, because each resident will have their own different barrier around why they don't want to drink or can't drink.
I had something on the tip of my tongue and it's gone. My brain.
You need a drink.
A no-show. I was going to ask. I was actually a no-show. It was to do with the fact that I know you have a background in prescribing, and whether or not this is anything that comes up in courses around prescribing about the use of antibiotics, almost prophylactically, not quite prophylactically, but let's give them antibiotics just in case. I don't know if you can put your mic on, Anosha. She can't. I'm sure I've got their mics enabled, but no. Okay. Did you look at antimicrobial prescribing, whether or not prescribing reduced at the same time as your reduction in admissions?
Yeah, well, yes, well, it's interesting, isn't it? Because I was asking the homes to tell me how many UTIs they had every month. So it may be that and I was at the same time trying to get them to use this UTI assessment tool. So it may be genuinely they had fewer UTIs, or actually they were simply better at not requesting antibiotics unnecessarily. Yeah. There's been some really good research into projects in care homes. And I can't remember, maybe this is one of the ones you've been involved with, Jackie, but lots of good research around it's available online. I mean, it's a couple of years ago that I did the project and the background, literature review around it. But I found there's so much stuff that's good that's available. Actually, some really good pieces of work in care homes that I did use.
Right.
Did you notice any difference with constipation as a kind of effect, that if you're better hydrated, you don't suffer quite so much from constipation, or may not need appearance regularly? Was there anything, any links there that you thought might?
And no, I simply talked about it as a symptom of dehydration.
Because I think what you did to feedback data is just so important, is it? That people need a positive feedback loop, that the impact of the effort that they're making is having all these different beneficial effects, and some beneficial effects are more visible than others. And knowing that someone has a sort of tendency to be constipated and actually doesn't seem to be such a problem now might be.
There was some anecdotal. Sometimes people would just mention that anecdotally. Oh yeah, so and so's constipation has improved. That's the kind of thing is quite difficult to gather from a care home. So I was quite aware that I didn't want to overburden them with in terms of what data I needed or would be easy or difficult to give to me each month. Yeah.
Anisha, I think you can talk now.
Can you hear me?
Yes.
Oh, great. Thank you. I don't know how I was disabled, but yeah, you asked a very important question with regards to prophylactic antibiotics. We certainly don't usually prescribe prophylactic antibiotics anymore because of the emerging resistance, and especially in the elderly. We have to prescribe with caution because most of our patients have polypharmacy. We've got to look at their renal profile and so on. So some medications do interact with other medications. So ideally, prophylactic treatments are not even advocated anymore, even in surgery.
And Antonella, I think you're enabled as well now. Where do you work? You've obviously got some really interesting perspectives on this. Shall I unmute you?
Just think she needs to leave, actually, but she's a community physio.
Okay.
Antonella's a community physio.
Okay. So Antonella, the question about getting to the loo is really important, isn't it? And I suppose one of the other things that we can look at is if that is a concern, is making sure people do have enough analgesia, so it's not quite so difficult for them to get there, and those sorts of things, isn't it? In amongst all the other things you talked about, Sophie. Okay. Well, I think we could bring this to a close. Thank you, Jackie. Thank you, Sophie, and thank you for our colleagues who joined us. The recording will be available, so I will try and reduce the quiet bits where we were waiting for people to join us, but and make it available. And have a good rest of the afternoon. Thank you.
Thank you.
Okay, bye-bye.
Bye.
Bye.